We described the common mechanisms of bacterial resistance to antibiotics and explained the mechanism of action and spectrum of activity of lipopeptide and beta-lactam antibiotics. Now, given a patient with suspected bacteremia, recommend appropriate empiric therapy. It's important to note that blood is a sterile site. There is no such thing as colonization of blood. Bloodstream infection refers to an infection of the blood. Bacteremia specifically means presence of bacteria in the blood. There is also fungemia, which is presence of fungi in the blood. Candidemia is a specific kind of fungemia, that's specifically Candida species in the blood. And viremia is the presence of viruses in the blood. Bloodstream infection occurs due to translocation of an organism from another body site or seeding of an organism to a foreign object, for example, intravascular catheter or a prosthetic device that communicates with the vascular system. When it comes to bacteremia, it is important to consider infective endocarditis, which is an infection of the cardiac endothelium, and it can present as either acute or subacute disease. Now, infective endocarditis requires imaging such as TTE or TEE. So TTE is transthoracic echocardiography, and TE is transesophageal echocardiography. So these are echoes that can actually look into the heart and see if there is vegetation present. We will not discuss endocarditis in this topic, and I refer you to endocarditis guidelines for further information. Let's take a look at common causes of primary bacteremia. Primary bacteremia is essentially bacteremia that's not secondary to other infections. So, for example, people with indwelling catheter can have bacteremia, so bacteria can actually find their way into the bloodstream through the catheter. It can happen through surgery. So people who have had surgery, there could be bacteria introduced into the bloodstream. Of course, people who inject drug can actually introduce bacteria into the bloodstream infection, into the bloodstream. Now, the common organisms in indwelling catheter bacteremia are coag-negative staph, Staphylococcus aureus, Candida, which is actually a fungus, and Enterobacterales. So mostly things from the skin. So the skin has staphylococci. So either Staphylococcus aureus or coag-negative. Those are the top two, and which also explains surgery. So essentially, because the surgeons will cut the skin open, bacteria from the skin can find their way into the blood. So Staph aureus and coag-negative staph are the top two, and of course E. coli can also happen, depending on the type of surgery. And injection drug use, again from the skin. So Staphylococcus aureus is by far the most common causative organism. Now, for secondary bacteremia, this is essentially bacteremia as a result of another infection. So, for example, a respiratory tract infection such as pneumonia occasionally can lead to bacteremia because the lung has very pretty good perfusion of the blood. So occasionally in advanced cases of pneumonia, bacteria can find their way into the blood. So Staphylococcus aureus, Enterobacterales, Pseudomonas, as well as Streptococcus pneumoniae. These are the top organisms that can cause bacteremia in patients with pneumonia. Urinary tract infections, the most common cause of urinary tract infections is E. coli. So in advanced pyelonephritis, for example, which is the infection of the kidneys, because there's a lot of vasculature in the kidneys, in advanced infections, bacteria can find their way into the bloodstream. So E. coli could find its way into the blood. The same is true with Enterococci. So Enterococcus species can also find their way into the blood from the urine. Now, less common is skin and soft tissue infections leading to bacteremia. So Staphylococcus aureus would be the most common on the skin, as well as coag-negative staph. In general, skin and soft tissue infections are not severe. So typically, unless there is deep tissue wounds and infection, it's pretty rare for bacteria to find their way into the blood from the skin. The same is true with intra-abdominal infections. So in the intra-abdominal infection, we have enteric organisms, so Enterobacterales, as well as anaerobic B. frag, so Bacteroides fragilis, and also enterococci. So enterococci are common in the GI tract. So if there are complications of intra-abdominal infections, these organisms can find their way into the blood. Again, this is pretty rare. Now, when exactly should we suspect bacteremia? So the clinical suspicion of bacteremia could be due to many things. The most common is the SIRS criteria. So the SIRS essentially is the systemic inflammatory response syndrome. There are 4 categories, and in order to meet the SIRS criteria, one patient must have at least 2 of these 4 criteria. So number 1 is the presence of fever, so the temperature of at least 38 degrees Celsius or 100.4 degrees Fahrenheit. That's the definition of fever. Or hypothermia, so if the temperature is actually lower than 36 degrees Celsius or less than 96.8. Now, hypothermia is relatively less common in infections. It's fever that's more common, but again, hypothermia is possible in patients with infections. Second criterion is a heart rate of greater than 90 beats per minute. So this is essentially the body's reaction to blood pressure dropping. So if somebody is having hypotension as a result of systemic reaction to infection, the body will try to compensate. So heart rate greater than 90 is the second one. Third is respiratory rate. So if someone having labored breathing, a respiratory rate greater than 20, or in more advanced, if you have monitoring that can actually measure, partial pressure of CO2. If the CO2 pressure is less than 32, it's a reflection of increased breathing, which essentially depletes the carbon dioxide. And lastly, white blood cell count of greater than 12,000 cells per cubic millimeter, or if there is less than 4,000 cells per cubic millimeter. Alternatively, if there is more than 10% bands, so bands are immature white blood cells. So if more than 10% bands, it's essentially indicating that the body is attempting to make a lot of white blood cells. So white blood cell more than 12,000 is obviously a response to bacterial infections. Alternatively, less than 4,000 is if the body has depleted the white blood cells as a result of dealing with the infection. So occasionally you may see actually a depletion of white blood cells because production cannot keep up with the demand. Now, it is important to note that patients who are receiving glucocorticoids, so let's say prednisone, for example, they can have increased the white blood cell count as a result of this. So that's something to keep in mind when interpreting patients' white blood cells. So if somebody just received glucocorticoid, it is useful to see the white blood cell before they receive glucocorticoid and after to see that this is truly a response to infection and not an artifact of receiving glucocorticoid. So it is important to have at least two of these four. For example, a fever alone is not an indication of infection, but if you have, for example, fever and white blood cell elevation, that's more likely to be an infection. And we'll talk about different things that can lead to fever because there are non-infectious causes of fever. The same with heart rate and respiratory. So if you have at least two of these, it's more likely to be an infection, and bacteremia will be top of the list. And next we have suspected sepsis. We will discuss sepsis on another day in the course, so I'm not going to go into discussion of sepsis, but typically when there is sepsis suspected, bacteremia is on differential diagnosis. If the patient has hypotension or shock, if the blood pressure is dropping, if patient requires fluid resuscitation and perhaps vasopressors in order to bring the blood pressure back to normal, should suspect bacteremia. Of course, if there is already indwelling catheter, you suspect that bacteria have been entering the bloodstream. And of course, some non-specific factors. So for example, if there are inflammatory markers that are elevated, so such as C-reactive protein or ESR or procalcitonin, for example, that's an indication that there could potentially be bacteremia in the patient. Now, when counting number of positive bottles of blood when we send them to the lab for blood cultures, it's important to know how blood cultures are obtained. In general, blood culture consists of a set of 2 bottles. So if each set have 2 bottles, and in each bottle there's 10 ml of blood. And of the 2 bottles in one set, one is for aerobic and one for anaerobic. So the way they grow them in the lab, they require different conditions. So one bottle is used for aerobic conditions, to see if there is any aerobic bacteria growing, and another one is used for anaerobic. Now, because it is possible to contaminate these bottles, so technicians use proper techniques to collect these bottles, but the techniques are not perfect, so occasionally they could get contaminated. So it's important to have more than one set of bottles in case there is contamination. Then you have a second set to verify it. So you end up with 4 bottles when you get 2 sets. So when describing positivity, the number of bottles positive will be described. So for example, you might hear that a patient had 1 of 4 bottles positive for Coag-negative staph. So that's what they're referring to when they talk about the bottles. Now, let's look at some possible origins of a fever. So of course, in this course, we are interested in infections as a cause of fever. But also keep in mind that other things can lead to fever, such as malignancy. So different types of cancer can lead to fever. Some autoimmune conditions can lead to fever. Even a DVT, deep vein thrombosis. Not in every patient, but occasionally some patients with the DVT can develop a fever because of that. And there's even drug-induced fever. So many drugs can occasionally cause fever, not in every patient, but occasionally they can. And when they do cause a fever, this typically happens after 7 to 10 days, when the first time the patient is exposed to these drugs. Now, if you discontinue the drug, it pretty much, the fever disappears pretty rapidly when you discontinue. And when you re-challenge the patient, it actually the fever develops within a few hours. So that's pretty much the only way to verify if this is a drug-induced fever. So if one, and the most common drugs are listed in this table. So for the sake of this course, beta-lactams can cause drug fever. Minocycline can, So if you don't have other reasons for a fever and you suspect one of these drugs, you essentially discontinue it. The fever should rapidly go away, and then you restart it. And if the fever comes back, you essentially conclude that this is a drug-induced fever. And of course, the worst case scenario, if you don't have an origin for the fever, is actually referred to as fever of unknown origin. Which going back to the SIRS criteria, it's important that if you only have fever and you cannot identify what's causing the fever, a fever alone is not indication of infection. You really should rely on the SIRS criteria, so you should find a second criteria to conclude that it's an infection. Now, let's discuss contamination of blood samples. So because blood cultures are commonly contaminated with skin flora, specific organisms may be contaminants. And the most likely contaminants are Coag-negative staph, Bacillus species, Micrococcus, Corynebacterium, Cutibacterium. So these are the ones that are more likely to be a contaminant. So what it means is that if you have 1 out of 4 bottles growing Coag-negative staph, you essentially conclude that it's a contaminant. But if you have 2 out of 4 growing Coag-negative staph, because you have 2 of the bottle growing, that's unlikely to be a contaminant. So you conclude that it's a true infection due to Coag-negative staph. Now, you only do that with these organisms. There are these other organisms that you never consider a contaminant. So Staphylococcus aureus, for example, because it's a deadly bacterium, if you only have 1 out of 4 bottles growing Staphylococcus aureus, you are obligated to treat it. You cannot count it as a contaminant, because if you happen to be wrong about the contaminant, Staphylococcus aureus can kill the patient pretty quickly. The same with the rest of these organisms here. So Streptococcus pneumoniae, group A streptococci, any of the gram-negative bacteria, Bacteroides, and even the fungus Candida species. If you have even 1 out of 4 bottles growing any of these, you should consider it bacteremia and treat it. Now, viridans, strep, and enterococci, these are tricky. So they may be true pathogen or they may be contaminant. It's really they are considered on a case-by-case basis, and typically infectious diseases physicians will be consulted for these to decide if it's a true infection or a contaminant. Now let's talk about management of bacteremia. So blood cultures before antibiotics are essential, if possible. So if even 1 dose of antibiotic can actually eradicate organisms from the blood sample, so it can actually reduce the yield. So it will be more likely that nothing will grow out of the blood culture. So it's important to get the blood cultures before initiating antibiotics. But I say if possible, because, for example, if it's taking too long for the, if the staff are not available to get the blood cultures, which is extremely rare, you don't want to delay antibiotics. So it has to be within reason. In general, you want to give antibiotics within 1 hour. But, if it's taking like 2 or 3 hours for someone to come and get the blood cultures, it's okay to give the antibiotics before blood cultures, because we don't want that to be, at the cost of harming the patient. Now, source identification. It's important to know how the bacteria got into the blood, right? So bacteria don't belong to the blood. So you need to identify the source. And that's important, because we're going to talk about source control. Because without source control, you can continue to give antibiotics. Once you stop antibiotics, if you haven't removed the source, the bacteria will continue to come back. So it's extremely important to identify the source. So catheter-related bloodstream infections, which essentially would lead that, to the fact that the catheter will have to be removed and replaced with a new one. You can so if there is a catheter in place, you suspect that is the source of the bacteremia, and the catheter tip, for example, can be cultured to see it grow something that matches the blood culture. Symptoms, you can use the symptoms to identify where in the body the bacteria are coming from. So for example, if there is pain, for example, if there is low back pain, you might consider that there might be kidney infection. So you can use the site of pain to identify where the infection is coming from. Or if there is inflammation in a certain location, perhaps maybe it's a joint, or anything that you can identify from the symptoms. Microbiological cultures of the site. So if there is a wound, for example, and you culture it and you grow something, and the same thing is growing in the blood, or if you have a respiratory culture and it's growing something that matches what's growing in the blood, that identifies the source of the bacteremia. And of course, sometimes you just cannot easily find the source, so you may need something like imaging to kind of show you, within the body if there are, processes that could be due to infection. And of course, you identify the source in order to have source control. So you remove the source if possible. For example, if there are extravascular devices such as central line or prosthetic joint, you essentially remove them if possible. And once the infection is treated, you can replace these. And sometimes they may require consultation of other specialties. For example, if someone has cardiac hardware, cardiology team may be needed in order to assess whether its removal is possible. And sometimes surgery is needed. So surgical debridement. So if surgically they need to go in there and remove dead tissue, any things like biofilm, which we'll talk about another day. but surgical debridement can also be helpful for source control. Now, for the empiric treatment of bacteremia, it is important to start treatment early in order to decrease the rate of mortality. And the choices of antibiotics really depend on the source, if known, and also on the history of the patient. So, for example, if the patient has a history of multi-drug resistant organism, then broader antibiotics are needed empirically. And of course, tools such as gram stain as well as rapid diagnostic tests are available to optimize the empiric therapy as soon as possible. Now, initially, empiric treatment should be intravenous because the infection is in the blood, and IV antibiotics give the antibiotic 100% into the site of infection. Now, there are some antibiotics that do not achieve enough concentration in the blood and should be avoided, regardless of whether oral or IV. So nitrofurantoin does not achieve enough concentration. It goes straight into the urine. Colistin, which is an IV antibiotic, does not achieve enough concentration in the blood, goes straight into the urine, as well as tetracycline. So tetracyclines, especially tigecycline, have very large volume of distribution. So they basically achieve high concentrations in most tissue in the body, but very little stays in the blood. So they are not ideal for bacteremia. In fact, there is a black box warning for tigecycline for increased risk of mortality as a result. And rapid diagnostic tests, such as multiplex PCR, are able to identify or select organisms as well as resistance early on. So within 24 hours of infection, these results can be available, which are often used in the sense that if one of these genes show up, then if the empiric treatment is not covering that specific resistant organism, then the treatment can be escalated.